Welcome to the Living Medicine podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
Hello, everyone. I'd like to welcome you to Living Medicine, where I interview interesting and influential people in the psychedelic-assisted psychotherapy space. And I am Dr. Sandy Newis. I am the owner and director of the Living Medicine Institute, which is a business where we provide a direct pathway to clinical practice for clinical and medical professionals who are interested in learning about psychedelic-assisted psychotherapy. So you can find us at livingmedicineinstitute.com. And I am very excited to be with Karen Sprinkel today. Karen is a clinician, an extraordinary clinician, and truly a trauma specialist. So I'm excited about this. And I think you're going to get a lot out of that, given how everybody talks about trauma. So let me introduce her a little bit more specifically. Karen Sprinkel is a psychotherapist, consultant, teacher, and author. She has written a book, and her unique East-West approach to healing trauma emerged over her years of living in Asia. So I'm excited to hear a little bit about that. Her specialty is a combined trauma modality and certifications using EMDR, brain spotting, somatic experiencing, IFS, ketamine-assisted psychotherapy, and psychedelic-assisted psychotherapy. She finished her master's degree studying Buddhism and researching the impact of trauma in Tibet, Nepal, and she also wrote a book that I myself have ordered. I'm really excited to read it, The Thriving Self, A New Paradigm for Treating Trauma in the Mind, Body, and Spirit, which she says is a unique roadmap to thriving beyond trauma. And Karen also has a podcast that she recently launched in trauma, psychedelics, and Buddhism. So Karen, thank you so much for being here. I really appreciate it. And you're in the Bay Area, correct?
Correct, Sandy. Thank you. It's an honor to be here. So thank you so much. And yes, I'm in Oakland, California.
Great. Well, thanks again. And I always like to share how I know people. And you know, the way that I met you was really touching because I was at Psychedelic Science in June of 2025. If anybody who went there knows, it can be kind of an overwhelming morass of people. And I was kind of standing there having some kind of lost moment, frankly, like, ooh, where do I fit in the world? And who are my people? And I don't exactly know how it happened, but you essentially like scooped me up and made me part of your group and gave me this moment of belonging. And, you know, out of that, we connected. And that was really special and quite trauma informed, really. So thank you for that. Yeah.
So I remember the moment very vividly, actually.
Yeah.
And there was an energy of really good peeps around us too. So
Yeah. Yes. And you had just done a demo for Dick Schwartz and Sonny Strasberg for their IFS presentation. So
indeed. Yeah. So it was very odd to look at myself on the big screen.
Right. Yeah. So, you know, tell me, I always ask everyone about kind of what is your pathway into the psychedelic assisted psychotherapy field. So, you know, whatever you feel like sharing about that, we'd love to hear that.
Okay. Well, I think you're going to find that I have a very unusual pathway in, which is because my pathway in was very resistant.
Oh, interesting.
My whole life have been in the belief system as a spiritual practitioner, at least I'd like to think I am, that in order to reach kind of spiritual planes of existence that are above our own, enlightenment, transcendence, that we must do it in a pure way. So I actually was anti-psychedelics. And
so pure in your mind at the time, pure meant like no medicine, no aids, all meditation, spiritual reflection, that kind of thing. Is that what you're saying?
Exactly. Like even back when I was in high school, I would party, and I'd have alcohol.
Yeah.
But, you know, it was like culturally accepted, but I never even smoked pot. Like I
interesting.
was such a purist, like a very pure girl, right? So I went my whole life also without even trying cannabis. So I was
interesting.
So pure to the bone, with some narrative I was holding, right? There was some cultural, familial, spiritual narrative that I was holding that I had to work through. And that was that in order to have spiritual ascendance, that you must do it in a pure way. So that was the first aspect of why I was purist. And then I've been a trauma therapist for a very long time. in the Bay Area. So over the past 20 years, I've also been receiving a lot of trauma referrals from people that had a bad trip.
Mm-hmm.
So that also added to my resistance of like, why are these people doing psychedelics when they have so much trauma in their background and what's going on here? So I was very reluctant and resistant to do psychedelics actually until 3 years ago.
Uh-huh.
Yeah.
Huh.
And I'm happy to talk about that if you want. Like,
Sure. Well, so what changed? Yeah, I mean, like, you can say whatever you feel comfortable saying, but like, what changed? How did you go from that to where you are now?
Pure intellectual curiosity. Like I kept seeing the research from the MAPS program, right? And I was like, okay, there truly is something here.
You're
And
right.
I kept studying it and I was like, okay, what is going on with this molecule of MDMA that's treating PTSD? And so I like followed the movement for about a year. And then I think it was maybe 3 years ago, there was the first PESI training on psychedelic assisted training. And so I did that and I was like, oh my gosh, I have to actually go get myself trained, like properly trained, not just this intellectual understanding of it. So then I got into the last cohort of MAPS, the last cohort that existed here in the United States. I mean, I believe now they're doing it in Europe.
Yep, that's where I did mine.
That's where you did yours?
I did mine in Sarajevo.
Oh, incredible.
I know, it was super interesting. Yeah.
Oh my God. Well, I would love to hear about that. That's
Yeah.
anyways, it was in the MAPS program. I remember sitting in the big, large group and also in the small cohorts they put you in, that I was so naive. I was the only person there that never had even tried ketamine. And I remember having this feeling wash over me of like, oh my God, Karen, what narrative have you been living in? Like, you need to let go of this narrative that if you really want to treat people, you have to know what you're treating them with, right?
Well, because it's so interesting. Because let me just kind of, so I mean, I'm kind of stuck on the word pure, and I don't mean to like, like I'm just gonna own it. Like that feels a little bit like elevated, like.
Totally.
So I can imagine like sitting there being like, wait a minute, these are also like elevated people. I mean, if we're gonna, these people are people who like seem also like they're doing good work in the world. Maybe we can just use that language.
Absolutely. Oh no, I was eating some big humble pie. Let's just put it that way.
That's
big,
so
humble pie. Like here I am, this really experienced trauma therapist specialist, right?
Just when I thought I was cool.
Profoundly elevated humans, and they're all kind of. No one was judging me, but I was like, oh, right? Like it was so naive. Where I was like, oh yeah, I have to try these molecules to know what my clients are going through,
right?
And it was like this huge humble pie moment where I was like, okay, I have to look at myself, I have to look at my narratives, and I have to let go of this purist mentality, which absolutely was kind of like viewing myself as better than. I didn't know that at the time. I really was following a Buddhist path.
Sure.
So I didn't think it was viewing myself as better than, but certainly it had that feel to it. Absolutely.
Right. Yeah. Right. It's super interesting because, in our training program, we have people who come in that are also similar, that have followed the Buddhist path. And, like you can't ever really understand unless you've done, 7-day, silent retreats and things like, which by all means, I have never done one of those and probably should and will at some point. But I do see that similarity when people are just like, oh, and I love that you are also really digging into that on your podcast. And maybe that's another separate conversation because I'm sure they intersect for you very much.
Oh, profoundly. Yeah. Like now that I have this light bulb moment, I am so into helping the Buddhist community merge with the psychedelic community and the trauma healing community, because we all need each other. Right. We all are helping humanity and we all need each other.
Yeah.
So, and we don't have to be siloed for sure.
Well, and this thing about you being really new, right? 3 years in is new compared to most of the people that I interview. I mean, I've been mission driven in this field for, decades. I mean, most people I know who are involved in it have been involved for a while. So I love that. And I love that you were a trauma specialist first. So let's really dig into that because I think you have a really unique perspective, like kind of going into it with new eyes from an area of expertise, including the Buddhist side. So, So I see you very much as an integrative thinker. I see you very much as having a high level of clinical sophistication, and I'm sure that goes in, right? So there's a gift there, and you being able to pull those things together. So let's kind of dig into this piece about the trauma specialist. So you have like all of the cool kid certifications. And I mean that like literally, like if I were to tell somebody like devote your life to studying trauma and get certified in IFS, brain spotting, EMDR, and I know that there are more, they're just not coming to me. Like, and you've actually done it. You not only are informed, but you followed the threads to the end of the actually getting those certifications. So when you're in it, you see how those things go together. But when people are new, they don't necessarily see that. So, let's talk first just about, what makes a good trauma therapist, and then kind of move into like what allows somebody to claim expert. And I know we all have that, like, am I expert? Like, no, but let's just own it, right? So, what makes a good trauma therapist?
Wow. I wish we had 5 hours.
Right. I mean, you've devoted your whole life to this and now you do training. So obviously, right. But if you could kind of summarize it, like what are the core tenets of what makes somebody good? And that might mean skill sets. Like what are the critical skill sets? It might also mean humanness.
Yes, exactly. Yes. Okay, so I have lots of ideas. I'll try to make this as succinct as I can. So please definitely interrupt me if I'm not succinct enough.
Sure.
Because I can go on tangents.
Right.
So the first thing I want to say is that we're all healers and we all want to help our individual clients or our collective clients or humanity, right? So we all are extraordinarily well-intending, right? All therapists want to help their clients heal. And so I can understand why so many therapists call themselves a trauma therapist or they work with trauma, right? I get it. And I would be not honest if I didn't tell you I have a reaction to that.
Sure.
Right? Yeah. So first of all, let's talk, maybe if I talk about the specialty, that will help me come back to like what the skill set is.
Sure.
So the first is, if we compare ourselves to a doctor, okay, like a primary care doctor. A primary care doctor sees multiple patients that has a heart condition, but they do not call themselves a cardiologist.
Yeah.
It's no different than a therapist that sees probably 80% of their caseload had trauma in childhood. It doesn't make them a trauma specialist. Right? It's the exact same thing. Just because your clients have trauma doesn't make you a trauma therapist. You have clients that have trauma, right?
Yeah.
So that's the first thing, because I think that needs to be named first before we get into what makes someone a skilled trauma therapist or a specialist and what are the skill sets that's needed. Okay.
So if I hear you correctly, you're saying just because you work with trauma, and then I would add recognize trauma, right, and know something about trauma, that still doesn't make you an expert trauma therapist or that you even work effectively with it. Was that what I'm hearing?
Absolutely. Just because you can spot trauma, your clients have trauma, doesn't mean you bring trauma to resolution. Right. Or I'd like to add, bring trauma to resolution in an efficient and safe way.
Ooh, nice. I love that.
Okay. Yeah. Because, again, a lot of therapists are very, very well intending, but can potentially cause re-traumatization. Right? And a client could be with a therapist for 5 years and walk away feeling so frustrated because they actually didn't really get that much better. Right.
Or maybe this is just as good as it gets.
Exactly.
I'm better than I was, but maybe this is as good as it gets.
Exactly. And see, that, what you just said, Sandy, is what breaks my heart as a therapist, right? So I believe it's our kind of, it's my mission, but I believe it's every therapist's responsibility to be just blatantly honest about what trainings they have and what they offer. But don't get into calling oneself a specialist or an expert unless you really are, right? And so I would say I've been a therapist now for almost 33 years, and I am just beginning to call myself a specialist, a trauma specialist. So the other category, I would say, which makes someone a trauma specialist is not just that they've treated clients that have historical trauma, developmental trauma, or clients have complex trauma from the past. They must have actually worked with acute trauma, acute stress disorder, right? PTSD, complex PTSD, dissociative spectrum disorders, DID. And if you have really treated all of those classes of trauma, then you can start calling yourself a trauma therapist, right?
Interesting.
Now, in addition to that, I am a firm believer that in certifications, and I'm a firm believer that we need absolutely at least one trauma certification that is experiential. I don't mean just like the PESI, CCPT of like you take this, 40-hour intellectual training on what trauma is, and then you call yourself a trauma therapist. I don't mean that.
Right.
I mean an actual certification program that has experiential, direct, firsthand practice, dyads, triads, right? And that would be the players that you already said, like EMDR, brain spotting, somatic experiencing, sensory motor, internal family systems, things like that, where the programs are actually 3 years long. You have to practice with your colleagues. You have to have consultation. You have to pass consultation. You have to pass certification. And you have to have at least one of those to say that you have something to treat the trauma. Not just that you have clients that have trauma, but you have a certification that can treat trauma. But even with one certification, I would still not call oneself a trauma specialist because that's one approach. Right? And this is what I also see in the community is that there's a lot of people that call themselves a trauma specialist and it's this approach and it's this way. And again, that can very indirectly and unconsciously cause harm to the trauma survivor. Because what if that approach doesn't actually work for them?
Right. Well, so here's where we kind of begin to branch off into kind of an almost like anxious place for me that I think others hold. Like, so, you are that unique person that did the thing, you did like all the certifications that you remember and carried them all the way through to the end. Like, say somebody's entering into this in their 40s or their 50s, and they're like, okay, I don't have 20 grand and I don't have, another decade to devote to like following each one of these certifications to the end. Like, so what do you think is the most important pieces? And maybe somebody can never really claim expert, but they want to be proficient. So, what are your thoughts on that?
Okay, this is also a deep passion of mine. Yeah, I would actually love to someday maybe even make a trauma institute or have a trauma board for mental health practitioners so that we actually have a board and a body that's actually giving people certifications to actually call themselves a trauma therapist, trauma specialist.
Right.
Exactly. Here we are. You and I are these seasoned clinicians, right? And even you and I are having to figure it out. Right. There's not like a board out there that says this is what makes you a trauma therapist. So
Totally.
I think that needs to be created. But someone else just asked me this recently on a podcast interview, and I really appreciated the question because they work with a lot of interns and a lot of, like you said, whether you're 40s, 50s, or you're in your 20s, and you want to be as effective as you can for a client. I wrote about this in my book too.
Nice.
I firmly believe that all of us as human beings store trauma differently. We store it either more dominantly mentally, cognitively, somatically, or spiritually. So because of that, if we really want to be an effective clinician that treats trauma, not just has trauma clients, then we need to have level 1 training in one of the cognitive approaches, one of the somatic approaches, and one of the spiritual approaches. Okay?
Yes,
And so because you have to have diversity, and again, your clients keep growing and changing too.
Right.
And your client might get past their narratives that they're running, right? But then they feel all the stuff on their body. And the clinician's not trained in nervous system regulation. So then what? Right? They might know what it is, They might have all the fancy terms, right? You see that time in and time out, everyone's using the fancy terms.
Right.
But that doesn't mean they're actually imparting that regulation on their client. Right?
Well, it's interesting because, like, one of the things, like, I mean, who doesn't love IFS? And I'm not IFS certified, but I would say I'm IFS informed. But, I see people getting so attached to that. And again, not a criticism of IFS at all, but that it actually becomes so cognitive that people can miss the body place, which is really where my emphasis often lies. I would say more somatic and spiritual and probably cognitive, kind of least. But it's interesting how we can get too into our modalities. Like, I'm just really kind of like owning that. I'm like, that's an interesting thing for me to ponder. So, yeah.
Thank you for pondering that. I actually wrote about that in my book too, about like the things that a therapist need or the client needs to ask their therapist, right? About like how dogmatic is the therapist about the approach, right?
Yeah.
Right? Like if the therapist is like, oh, this is the way. Like this is IFS is the way. IFS is all you need. I would caution against seeing that therapist actually, right?
Yeah.
It doesn't mean that IFS isn't profound. I personally love IFS, and it's when we combine IFS with ketamine, it's like unbelievable.
Yeah.
But it doesn't mean it's the only way. So there's no only way, first of all. And for clinicians, what happens, we're humans, right? So we like to share what helped us with our clients, right? And that's where we have to be cautionary, right? Like our clients have different systems than we have. Like you said, you're very somatically minded, right? You're very much into earth and doing things outside, and you're more like an eco-psychologist, right? And you're very somatically driven, very spiritually driven.
Super experiential.
Super experiential. But
like less cognitive.
That's really cognitive. So what are you going to do, right?
Right. Yeah. Yeah, so it's just, I mean, it's interesting. And that's just, and one of the things that I'm just noting here is just, I'm always kind of pondering the whole heal thyself thing. Like, realistically, like most people who specialize in working with trauma have their own trauma stuff that they're working with. Not all, but many. And so it's an interesting parallel how we go into our lives into what heals us the most. And then we can assume that it's the same for others, and it's not.
Exactly.
So, yeah.
And so even if it is, they may change, right? Your client may change in a year.
Right. Yeah. Right. Totally. Yeah. And I want to you named one thing that I just want to highlight to just like to make sure that it gets out there. Like it is of critical importance, in my opinion, to be able to recognize dissociation and subtle and mild dissociation, not just like a full on frozen, but subtle and mild dissociation, and that place where you might be seeing some DID like things, which we can call parts. And that is so important to be able to recognize that. And because that just takes a lens of watching for it, right?
A lens of watching for it, but also recognizing you're only seeing what shows up in your office.
Right. Totally. Yeah.
And so I've always kind of been more like a social worker / therapist. And I am always a believer in my clients seeing other practitioners as much as they want to. And one of the questions I always ask clients is, how you are with me, is that how you are out in the world?
Oh, that's a really good question.
Because, right, we all want our therapist's approval.
Yeah.
Right. Or we may only share our dark side with the therapist, right? So it's like, that's where you really get some interesting answers.
Ooh, I'm going to put that I'm going to file that away in my, that's a good one. Right. And I can see how it is of critical importance. And so that kind of segues us into psychedelics, because then we have this whole other level, is how you are on psychedelics the same as you are in the world, and what's similar or different, like obviously, right? But there is more to that. Like, the process of like, I have a very experiential lens and came from a background in outdoor-based experiential education and therapeutic adventure. And that's very much the way you do one thing is the way you do everything lens. So, and then relational pieces come into that, attachment styles. And, I view psychedelics as a super relational intervention, whereas not everyone does. And so, to me, that also then leads us into the trauma pieces. And so, let's talk about trauma-informed psychedelic care. And I want to just name kind of a cultural piece that you and I have talked about, which is let's just, the MDMA research realistically is what brought us, onto the map in psychedelic assisted psychotherapy. Although ketamine has been kind of working in the sidelines here always, never having been illegal and kind of paralleling that. So now we have this interesting cultural piece where psychedelic assisted psychotherapy, the original research, which is awesome and critical and important, brought us into trauma. That's then paralleling an emergence of awareness of trauma in the non-psychedelic world amongst the therapists. And now you have in ketamine land, you have every person who does ketamine work, whether they're doing CAP, ketamine assisted psychotherapy or not, they're saying that they work with trauma and PTSD. So we have an interesting world in psychedelics that has a lot of pros and cons. I wouldn't want it any other way because here we are, but kind of like, how do we move to the next level where we can actually talk about trauma-informed or trauma-specific psychedelic care?
Oh my gosh, Sandy, this is absolutely my passion and wheelhouse for sure. Like yes, again, like the same board that we need that for psychedelics too.
Right.
Yeah.
Yeah.
And I wrote my final paper I mentioned to you at CIS on how we have to have trauma-informed to trauma-specific care with psychedelics. So again, let me go back with I want to preface all of this to say we're all well-intending.
Yeah.
Psychedelic healers are very well-intending. Doctors in hospitals, well-intending. Anesthesiologists, well-intending.
Absolutely.
And that doesn't mean we don't cause harm.
Right. And many people do get better. Let's just, let's name that again. Many people get better without a trauma-focused therapist or trauma-specific therapist. So, and like what I hear you say is there are also many people who could get a whole lot better than they did, right? Or are even harmed. So let's kind of focus on that.
Exactly. So, and because we're still kind of early in the second renaissance, I understand why there's so much confusion. And so I actually started my paper by breaking down the different sectors, right? So I think in order to discuss this, we need to briefly discuss the different sectors, right? Like we have this transcendental indigenous wisdom sector, which we all hold deep respect for. And that is one way of holding psychedelic healing, right? Of collective journeys, going to Peru, having ayahuasca ceremonies with a shaman. And that's one way, right? And that will continue, but that's not mental health trauma-informed or trauma-specific treatment, but we can still honor that. And I want to just, to icing, like I want to honor that there's indigenous wisdom out there, and that's been going on since the beginning of humankind, right?
Right.
And that will continue.
Right. I mean, and, an interesting, I think, useful kind of lens is that there's therapy and then there's therapeutic. Like, so people can go and have a profoundly therapeutic, life-altering experience in those contexts or other contexts with psychedelics or other non-ordinary states, but that's not psychotherapy. And that's okay. That doesn't mean that you have to do psychotherapy or that has to have psychotherapy, but there is a distinction.
Thank you so much for using that. Therapeutic versus therapy. Exactly.
Yeah.
And that moves into the two other sectors, which are like psychospiritual development and or like conscious healing. Like you're choosing to go and have a psychedelic journey to help you with something that you feel like you can have your own experience with. Okay. Again, all of those are therapeutic, to use your terminology. I love it. And then we have the biomedical model. And this is where so much confusion is happening, right? We need, at least in places like North America, Australia, but North America specifically, we are all at the mercy, basically, of the biomedical model, right? Like we have our treatments paid for if we accept insurance by a biomedical model. And so because ketamine is the only nationally approved molecule, it has been given by the biomedical model, right? So we have anesthesiologists, we have doctors in hospitals, we have ketamine clinics, and there's no assisted therapy attached to it, okay? And again, that's not wrong. It's could be healing, it could be therapeutic, but it's not therapy.
Yes.
And in those moments is where I've been getting a lot of referrals because people have traumas come up for them and they're not being held, right? Or
Totally.
desensitized or reprocessed when it
Mhm.
could have been.
Yeah.
So my important point is I think that we need to get into what sectors we're talking about, right? So we're not talking about indigenous, psychospiritual, biomedical. We're talking about therapy sectors.
Yeah.
And biomedical to therapy sectors,
Mhm.
there can be traumas that come up during the psychedelic medicine, right? That one forgot about, they were buried.
Sure. Yeah.
And or we can have traumas that come up from the psychedelic medicine.
Right. Right.
And this is why I wrote my paper,
Uh-huh.
because in the programs and the books, there is so much, in my opinion, gaslighting of the client's journey when they've had a traumatic experience come up from the psychedelic medicine, that it was meant to be.
Right.
It must be coming up for them to heal. Their inner
Yes.
healer will heal it, right? They must go in and through it.
Oh,
And as a
yes.
trauma therapist, I'm like, whoa, wait a minute. Whoa, hold the
Right.
brakes, right. It's like, okay, that works in indigenous, psychospiritual, maybe biomedical. Yeah, that doesn't work in therapy. I'm sorry.
Well, and it might work in that particular, kind of ceremonial model, because that originally comes out of a village where you have belonging and where you have shared experience and you have a collective belief in the process. So you also land in a world that welcomes you back and thinks what you went through is normal,
Exactly.
right? Whereas that's just not, I mean, that would, in an ideal world, I'd love that some people have that, but not all of us do in the Western world.
Exactly.
And so let's name that piece too.
Yeah, so thank you. And so in our Western world model of mental health treatment, we usually see clients individually, to your point, right? Not in a sense of belonging community.
Yeah.
And so for me, if we are going to be psychedelic clinicians in the world, at bare minimum, we must be trauma informed, which means we have to have had at least level 1 experiential training, not
Yeah.
intellectual training, in one of the trauma approaches.
Yeah.
Or we need to have on like fast speed dial a trauma therapist that lives in our community that we can get our client into immediately following a psychedelic journey if they had a traumatic experience. Like,
Mhm.
I think that's vitally important. And I think we need to really start naming that distinction because, again, there's so much of an ethos in psychedelic trainings and community that everything is meant to be gone through, right? Like,
Totally.
and
Mhm.
the inner healer will solve it.
Yeah.
And that, I'm sorry, even in the IFS model, we know that's not true. I mean, we can have a firefighter, a manager come in and really prevent ourselves from having a healing experience,
Mhm.
right? So we
Mhm.
really have to kind of know when to intervene and not only say it's the inner healer that will help.
Yeah.
And if the inner healer doesn't help, then it's the client's fault, basically. Like
Oh, for
something,
sure.
yeah,
Right. And I think it was maybe Raquel Bennett, who, was just a wealth of knowledge in the,
yes,
ketamine assisted psychotherapy field. In a conversation, she mentioned she was talking about how the biggest number of adverse effects with ketamine that show up in ERs are psychological.
yeah,
And then I kind of added on to that. I think that because of this, people who do have traumatic experiences and are not healed when they have this expectation that they're going to be healed, often just kind of go away in shame.
exactly.
And they don't really come back because they don't identify it as a traumatic experience or as a trauma that emerged. They identify it as they did something wrong because everybody told them that they're supposed to just go through this and come out the other side better. And that's that whole let's lean into the fear. If you feel the fear, go towards it. I don't know. I'm not so sure. What if we kind of danced around the fear and just noticed that part?
Or what does the fear mean? I mean, there's so many different approaches, right? And it's
Right.
like you have to match it for whatever the client system or meaning
Mhm.
making mind is making out of the fear,
Yeah.
right? I mean,
Yeah.
we might even need a different intervention right in that moment. It might be a
Yeah.
somatic containment hold, right? It might be just letting them know we're here, it's going to pass, it's a round trip ticket. It may be that you ask them what their meaning is and then you help them know there's other meanings too. It could be that you actually have to use some desensitization and reprocessing and tap on them rapidly, left and right, right? It could be you have to help them move their eyes in a certain different eye gaze position so they know they still have mobility as they're laying there. There's so many different things that we could do. And rather than just say, oh, it's meant to come up and it will just naturally heal. You're meant to experience this.
Right.
Yeah.
Or, well, in ketamine, like you're not with a therapist, or maybe even if you are, and you're sitting there kind of like, oh, this is, ick, and I don't know, and I don't even know if this is working, and and then we're supposed to have this pharmacological effect that we're supposed to feel magically better 2 days later, and we don't.
That's the other trauma that can come up, right? The nascent effect, right? Like the opposite of the placebo effect as well. There could be the disappointment that nothing will work because I was so relying on this ketamine to treat my depression.
Yeah.
And now I feel hopeless.
Well, and I would just name that, like, a lot of the people that I have seen using CAP, again, as I've said before on here, but CAP to me is preparation, medicine, integration. They are not separate. I would, like us to eventually stop calling it preparation because it's too much of an emphasis on the medicine, but it's a whole package. It is not just that we like sit in the medicine. But a lot of times I'll see depression remit with ketamine, and then people are left like, then they're like, relational trauma pieces are just like up front and center. And suddenly they're like, I'm more anxious. But that's not supposed to happen. I'm supposed to be better. So then we go into freeze and we're going through the world being like, well, I just spent a whole bunch of money and I'm feeling better. I'm not depressed, but whoo, because that depression can be a protective blanket, kind of tamping that down. So, let's just kind of name that as well.
Sandy, thank you so much for naming that because what you just named also goes into the prep part, right? So the integration is directly also tied to the prep where we have to be properly assessing clients, right?
Yeah.
And granted, we all know that we have no idea what's going to come up during a journey, right? Of course we know that, but there's a lot we can know.
Yeah.
And that's part of the prep. And I would really like to see very trauma-informed, trauma-specific questions in the preparatory sessions, right?
Like what?
So for example, usually we can do it many different ways, but using developmental stages, right? Do you feel that there's anything from 0 to 5 that you still get triggered by? And almost everyone says, well, yeah, there, boom, I'd write that down, right? 5 to 10, like think about kindergarten, first, second grade, anything that's still, oh yeah, I still remember that second grade teacher and made me write in front of everyone, blah, blah. Okay, I write that down, right? For me, my intake involves the top 10 worst memories of life and the top 10 happiest. Usually from the top 10 worst, I have an idea of their trauma presentation. I also have my own assessment, which I call the trauma type questionnaire. So I can kind of start getting a window in. Are they more like trauma mind? Are they more trauma body? Are they more trauma spirit? Right. So I kind of have a preparatory analysis of interventions that might be needed, keeping my mind open and flexible that it may be entirely different during the journey. But if we go in and only ask the standard like demographic history taking questions without what still has a hold over us, that's not really trauma informed. Like I see a lot of intake forms that just have everyone write down like the questions on the Beck depression scale or the anxiety
presenting issues. What are you struggling with? Tell me more about that.
Exactly. But what still has a hold over you? And it's amazing. Talk about dissociation. It is phenomenal when I have assessment questions for trauma, how many folks, including myself, maybe you too, Sandy, forgot about traumas that happen. Like one of my questions is, have you ever had a car accident? I can't tell you how many people are like, oh yeah, I forgot when I was 12 years old, I had that car accident and we flipped around. And I'm like, okay, right.
Well, that's a thing.
Right?
Right.
Like you have to also ask the right questions. So in my book,
Mhm.
there's like 200 questions, by the
Oh
way.
my gosh.
I have
Oh,
first there's
thanks for plugging the book. I can't wait to read it.
yeah, right. Well, there's
It's on the way.
yes, by the way, the book, but no, I wouldn't say it unless I really believed in it.
No, I
If you're
believe
really
you.
trying to be
You
trauma
mean
informed or
this.
trauma
Yeah.
specific, you really have to like know the whole spectrum of how trauma has a hold over us.
It's so interesting because I very much have a like a relational trauma lens and maybe a little less event specific than I even could be because that's really what I'm assessing and it's also where my vulnerabilities are. So there's certainly a piece and so, so I'm always like, tell me about, your internal state and what was life like? Same thing. Like, what was life like for you, up until approximately first grade, and, did you feel, sad or mad or scared or happy just to kind of get a sense? And then, how were your relationships? Like, do you remember? So it's just interesting.
It is interesting, and that's all relevant too.
Yeah. Right.
But that's a piece of the pie.
Mm-hmm.
Right?
Mm-hmm.
Because we're looking for intrinsic resiliency, intrinsic resource. And in
Mm-hmm.
order to know if one has intrinsic resource, it has to be not just in relationship,
Right.
right?
Yeah.
Because they're going to need intrinsic resource in a psychedelic journey.
Totally. Well, I'm looking for relational traumas in that. I'm looking
Yeah.
for disruptions and, areas where people weren't cared for. But anyway, like
Yeah.
so you're recommending trauma specific questions and then one of the things I think I heard is that you're wanting to kind of also map on where the trauma lodged for the person kind of you have talked about a cognitive, a somatic, and a spiritual perspective. So I imagine you're kind of tracking that.
Exactly.
And then if you are a trauma expert, as you are, then you're also going to be choosing the types of interventions that map onto it while also being open for the fact that you could just be wrong. I can't say that, but I will add that. And you have to be flexible.
You must always know that you can be wrong at any moment,
Yeah.
right? That's
Yeah.
vitally important. Always stay humble. And then the other two things always to keep in mind is always stay humble, always still defer back to the client in choice. As a trauma survivor, all clients need choice. So that means choice of medicine, choice of music, choice of where you're going to sit next to them in the room or not sit next to them in the room, choice of mask, choice of not mask. I mean, you can offer your preference and give them the psychoeducation on why wearing a mask is important. But if you have a trauma survivor that was kidnapped and blindfolded, I'm sorry. Right? Like they
Let's
don't
not
have
do
to
that.
wear a mask in the ketamine journey, right? Like that's just kind of for me basic common sense, but I can't tell you how many people I've had who have told me they told me I had to wear a mask and it was it was traumatic for them.
Right.
It caused more trauma in the journey because they didn't have the choice, right?
Right.
So
Yeah.
there's the choice and then the ability to pivot. Pivoting is vital too. So not getting stuck on, okay, this person has a strong cognitive negative cognition. I need to keep on EMDR when they come out of ketamine. It's like, no, no, no. What if they're having a somatic flashback? So then I need to then move and pivot to having more somatic containment, somatic resiliency, right? Or somatic discharge, whatever they're ready for. Yeah.
That's so interesting. And, one of the things too is again, just like that ability to pivot. And so, say you don't have that. Like, say you don't have the list of, the cognitive, obviously, it's not a list for you. You're like living it, you're embodying it. But say you are more trauma informed, right? But maybe don't have all of those things. What would you kind of recommend as the biggest things that people need to have? Like, something that they can do more, like that they may already be doing, but that they can do more. Specifically, let's bring it into the realm of ketamine assisted psychotherapy. Like, what are the kind of critical elements? Again, I don't want to mean that therefore you can bypass all the other stuff and just get really good at these core things. But what are the kind of core tenets of if you're not certified in all the things or informed in those pieces, what can you do? Like tomorrow, like what could you do better in the next week?
Well, okay. Obviously, I have a bias. So I think anyone that's a ketamine assisted psychotherapist should be getting themselves level one trained in one of
Yeah.
the trauma approaches, right?
Mhm.
Just because we don't know what's going to come up.
Mhm.
But if you can't get into something for a year, right? You can't get into the
Mhm.
program, or you don't have the means, the financial means to do it, then so again, thinking through the lens of mind, body, spirit,
Mm.
mentally, how can you help your clients, even if it's using cognitive behavioral therapy, right? How can you help your clients recognize that they're even in a narrative,
Mm.
right?
Mm.
And can you get your client to agree to unpack that narrative in the post integration session, right?
Mm.
Like even just
Mm.
naming it is
Mm.
helpful. Like
Mhm.
if you don't have the skills to do like EMDR or something like that, even just bringing awareness to what
Mhm.
does need to get healed is healing.
Mm.
Right. So we don't want to
Mhm.
avoid it, but we don't want to say that we are treating it if we don't know how to treat it, but we
Mhm.
can name it as being in the room.
Yeah.
Right. We can name that, oh wow, your scarcity narrative is really up right now. You had to pay
Mm.
all this money and you didn't have the experience you wanted to ketamine. By the way, that's a common thing, right?
Oh, yeah.
Yeah, people pay all this
Very
money
much
for
so.
ketamine and they're like, ah, it's so frustrating to spend all this money. It's my whole what I pay my other therapist for a whole month and it wasn't that
Mhm.
profound. And it's like,
Yeah.
oh my gosh, I would just want to hold. I can really hear this narrative in you that like there's a
Mhm.
lot of scarcity. You're feeling a lot of scarcity right now. Is it
Mhm.
okay if we work on that scarcity in our next session, right? Or
Yeah.
in our
Oh,
integration
nice.
session,
Mhm.
right? Like just
You're
even
naming it in the hopes that then they'll feel supported in that, and then they may be able to let it go a little bit or, like, open up. I call it soften and allow. They may be able to soften and allow themselves to move through.
yeah, you're just acknowledging. Exactly. I love that.
Mhm.
Acknowledge,
Mm.
soften, and allow. I love
Mhm.
that. I love that.
Mm.
Soften and allow. It's like you're not gonna like personally take attack that they're like it's really common that people feel like they've wasted their money, right? And they
Oh,
didn't get
yeah.
the journey they wanted. Yeah.
Mhm, especially if they get a little worse or even a lot worse, which can happen when that depression remits and suddenly the anxiety and the anxious hypervigilance is right there.
Right. And then for those folks, just a quick segue, I always give them psychoeducation on big swings of pendulation in the nervous system, right? And
Mm.
if they were in depression, it's really, really common as that starts to heal, it's going to swing into more of arousal, which can present as anger or anxiety. And
Mm.
usually just again, that psychoeducation for the somatic stuff is a way to have it soften, right? To
Yeah.
acknowledge, have it soften, but to really trust in that process too. Like there is a
Mm.
larger pendulation that's happening. And
Mm.
what I also like to provide psychoeducation at that point to my clients is that sometimes psychedelics don't heal what we think it's going to heal, but what we're looking for is a state shift change. I
Mm.
give a lot of education on why the state shift change is important because we don't ever have, even without getting into the BDNF and the all the different like brain chemicals and all that stuff. Just
Right.
saying, there's a difference here, right? Like
Yeah.
now you're feeling more anxious than depressed, so we
Mhm.
know there's been a state shift change.
Yeah.
So that means we know you're healing. You're not healed, and
Yeah.
we're going to keep working on getting you to feel healed. But actually, this means you're healing.
I love that. I talk about state versus content, that it's not
Yes.
all about content. It's not all about the aha moment. Right? Instead, that we're looking for a shift in state and and ideally a shift towards, being okay, if not well-being. That it becomes more okay to feel okay when you're okay, which comes from a friend of mine, Katie Asmus. Like,
I love that. Reminds me of the book It's Okay to Not Be Okay, the grief book.
right.
Yeah. Yeah.
But then can we also be safe? Can we feel safe feeling okay?
Yeah.
Can it be okay to be okay? It's like a really, even though it sounds so simple, it's a really profound thing to ask.
Well, for trauma survivors, that's a perfect example.
Yes.
Is it
Yeah.
safe to feel okay?
Yeah.
Right? Yeah.
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 And that's why, as we know, a lot of trauma survivors with relational trauma, they feel really uncomfortable being in therapy.
Totally.
Yeah.
Yeah.
Feels
Yeah.
uncomfortable to be with a safe person.
Yeah.
Yeah.
So things I'm hearing you say are name something when you see it, name one
Yeah.
of the dynamics, name it, acknowledge that it's coming into integration,
Hmm.
right? Some psychoed around state shift, that state shift, some psychoed around the, significant fluctuations that can happen through the healing process, both with
Yep.
psychedelics and not, so that people have a sense, I'm adding this, so people have a sense of control. And I
Yes.
like that they can name
That's
it
right.
when it happens. Like, oh, I always say, like, oh, like a thought bubble over my head. Like, oh, I get it. I'm doing that thing that I do. Like,
Yes. I
oh,
love
I get
that.
it. That's what Karen said would happen. Great. Doesn't mean it feels awesome, but I know that this is a thing, like,
Totally. Exactly. Yeah,
yeah.
it gives them control and self-agency. So yeah, so mentally it would be naming the narrative, acknowledging it. Somatically, it would be just naming state shift change.
Hmm.
And then spiritually, it would be either the meaning making mind, or maybe there is a younger part that is
Hmm.
really feeling tender right now. Because
Yeah.
spirituality doesn't just mean meaning making mind. It's also how we view humanity, and it's also
Mm,
how we hold all of our parts of ourselves.
mm,
So as we know with psychedelics, it brings up a lot of questions about humanity as well. We usually have a broader spectrum of thinking about what it means to be a human as as a
mhm,
human race. And so that's where the therapist can just really hold the container and the space of, oh, you're starting to have a shift in your meaning of what it means to be human. And this is going to be really important for us to follow up with. And then vitally important in the integration session, if there's anything the client is still feeling unresolved with, you again must have therapists that you refer to that are trauma specialists, right?
yeah, I
Yeah.
love that. It's interesting because you talked about the little girl, or the little girl. I'm, identifying as female identifying, but the young part. And
Mhm.
it's interesting because in my own, like, therapy, I've always had therapists be like, what can you bring to this young part? And I'm always like, I don't know. Like, but like that phrase, there, it's so like it's just been like a phrase. But what's interesting is that, and I actually got this from Dr. Ron Siegel, who's been a guest on this twice, whose work I really value, and it overlaps with the Buddhism piece, which
Yes.
is bringing self-compassion, like having compassion. That does work for me. And so it's really interesting just how, like, just kind of like tracking that with the client. Like, because even you said that and I felt that, like, I'm like, ugh,
Yep.
she's saying the thing. It
Right.
was just funny. Like,
But and I saw that, and that goes back to just the wisdom that language matters, right?
yes,
And
yes.
how our client orientates matters. And a
Hmm.
client, I have so many clients that hate the language of parts.
Yeah.
And even if I change it to like aspect or so, I even have a Dharma teacher that just says, Karen, stop using parts language with me. I can't stand it.
But I can't help it. I love
Right, right, right.
it.
So and then we chuckle and we laugh, and then we use just mindfulness language, right? So but
Hmm.
language matters, and how
Right.
our client orientates matters. Absolutely.
Well, and I would add, because I think it's in alignment with what you're saying, like be able to be flexible in that language.
Yes.
Like, if the language of parts doesn't work and the person doesn't want to freaking, meet the needs of that like little girl, but rather
Totally.
can kind of operate from a place of compassion. And, like that critical piece being like, compassion doesn't really mean pity. Compassion to me is softness.
Yes.
Like compassion
Totally.
to me is sweetness, but that's a me thing. But it's just,
Mhm.
I'm just bringing that up as an example about like noticing how the flexibility and how we can say things and do things that have the same intent, but by shifting the language and shifting the approach.
Absolute language flexibility and cognitive flexibility. Absolutely.
Right.
Yeah.
Like I had an interesting realization lately that I was getting kind of too much psychoed. Like I think an amount of psychoed is critical, but
Mhm.
that I was getting like too into like, myself and teaching and all these
Yeah.
wonderful pearls of wisdom. And I've been just experimenting again with just like basic reflective listening and
Mhm.
like basic validation and empathy. And I'm like, oh, interesting. Like, let's go back
Yeah.
to the basics of that relational safety and feeling cared for.
Totally. Totally.
So, anything else you want to share? I know that we're kind of reaching the end of our time. So, after kind of all of this, what would you like to kind of, impart to the world? What else do you think is important here?
Well, to the client that's listening, I want any client or any human that's wanting to heal to really receive that there's so many pathways to healing, and
Mm,
please never give up. And that means even if you've had a psychedelic journey that didn't go how you wanted it to, please do not give up. Like there's
yeah.
so many variables, and there's so many pathways to Rome. There's so many different clinicians. There's so many different molecules. There's so many different trauma healing techniques. Please do not give up. That's what I want the client to hear. The clinician, please get yourself at minimum trauma informed. Psychedelic therapists, please get trauma specifically trained.
Yeah.
Or again, if you can't right away, get that trauma therapist on your speed dial so you have a person you can collaborate with or send your client with and share cases with. And humanity. I really believe these medicines, I've completely shifted, come full circle to the first 5 minutes. I really believe that psychedelics can heal humanity now. I really do. Yeah. But the only way they can heal is if they're trauma informed. Because the last thing I want to say, we've been talking about traumas that can come up, but what I think is important to name, which a lot of people don't like talking about, is darkness, right? And there can be darkness. There can be, people talk about entities. There can be something that we did that we need to be accountable for, right? So sometimes it's hard. Sometimes it's difficult. But there's always the other side. Always. So if you experience something that feels dark, or you look at humanity in a dark way, there's always another side. If you had an experience in the past or presently where you feel like there was some kind of weird entity you saw, there's always healing, always healing, right? Yep. And if there's something that came up, and even there's something right now that you're holding back from sharing with your therapist because you have so much shame about it because you caused harm to someone, it can get healed. Get healed, right? And sometimes accountability is also how we heal things. So it's the whole spectrum. Everything can get healed. That's what I'd love the viewers and the listeners to hear.
I love that. Well, thank you so much, Karen. How can people find you? So how do they find you? And I'm also aware that you have some upcoming things coming up. If you want to kind of, say those as well. I want to be sensitive to your time, but if you want to, anything you want to share about that.
I think that's just the biggest thing is you can contact me through my website, which is KarenSprinkel.com. I have an Instagram account too, which is The Thriving Self Now. And the biggest thing that's coming up is just my own podcast, which is Trauma, Psychedelics, and Buddhism. And I am deeply passionate about integrating Buddhism with healing, trauma healing, and psychedelic healing. And that's kind of the main stuff coming up. Yeah.
Awesome. Great.
Thanks for asking.
Well, thank you so much. For those that are listening, I highly recommend, as you've already seen, I think Karen has a unique ability not only to treat, but also to teach. So you have a really good capacity to articulate it in an applied way. So I think I can imagine that your trainings are probably really quite good.
Oh, thank you. And Sandy, that did just remind me. I can't believe I'm forgetting. I'm so sorry. This is really important. I am teaching psycholytic dosage of ketamine training through the Joyous. Do you know Joyous? Joyous. So Joyous is a national company that prescribes psycholytic dose of ketamine. So I am offering their ketamine training, and I'm so sorry that I'm blanking on the date. I think it's the first Saturday in December.
Okay.
So that is important if there's anyone, both client or clinician, that wants to really understand how ketamine can be used in just an hour session or actually to treat their clients at home, then definitely log into that training too. And that training is through Joyous and Engage Mind CE.
Oh, great. Good. All right. Well, thank you so much. I really appreciate it. Thank you so much for being here.
And Sandy, thank you. And thank you for willing to keep growing and learn. I love your growth mindset and your humility. So thank you as well.
Well, thank you for that. All right. Bye-bye, everyone.
Bye, everyone.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.